And this has really been a fantastic meeting. And so I'm going to talk about the really part two of Stan's talk in some sense. It was very fortuitous. But I'm going to start out with a little quiz. Okay, and the quiz is what is the relationship between AI and the ratio between the height of a giraffe and the diameter of a red blood cell? So you hadn't thought of anybody ask you that question today. Okay, so seems a little off topic, but in fact it's not. And so that is actually roughly a factor of 1 million. And that is the amount that computing has improved in terms of speed in the last 25 years. And as it turns out, Jack Dongarra, who throws a sort of wonderful party, and he does many things, but what he's probably best known for is carefully benchmarking the speed of the fastest computers in the world. So I actually was just at a little workshop with him. He's actually very interested in these topics as well. And it was almost exactly a factor of 1 million between 1994 and now. And actually my group had programmed both of those machines. So one of the things that's actually really happened is it's not really that people 10, 20, 30 years ago didn't think about algorithms that are now called AI, and there's talk earlier about the AI winter and all of that. It's to a large degree that the computational ability didn't really exist to do these things. Okay, so that having been said, as Stan has pointed out, every diagnostic whole slide image contains a tremendous amount of information, and AI can perform a variety of different tasks, and the tasks in pathology range from very concrete but very critical, which is you take a pathology image, you look in a microscope, you say, well, what's down there? And you see a gazillion cells, roughly, if it's an excision, roughly 1 million. So for instance, one of our data sets has about 10 billion segmented cells. So you have lots of cells. And the Stans of the world, I'm a mere clinical pathologist as well as computer scientist, by the way, so but Stans of the world, honorable anatomic pathologists, look at these images and have traditionally sort of said, okay, it's Gleason group X. They generally don't say cell 400,622 is looking a little mitotic today. Just wanted to give you the heads up on that. So, but the current algorithms are rapidly making it possible to electronically circle and classify all the cells. So that's really something you couldn't do. And it's also very concrete because it sort of has a very specific biological interpretation. Okay, the algorithms can also classify, okay, and they can classify and emulate humans, as in Gleason group and glioma and non-small cell lung cancer classifications. They're subject to error as well, as I'll talk about, as Stan alluded to, but I think that they play a really important role. Then I'm not going to have time to get into some of the pathology analogs of what was talked about earlier today. The predicting the future is very popular, it always is. And the sort of approach where one has a survival function and you do an optimization that takes into account pathology, and it could also include radiology and omics, and then find out what sort of tissue is predictive, very similar to what we heard about this morning in terms of mammography and radiation treatment. So these are sort of themes that cut across. And then there's also the important thing of putting us out of business, which fortunately I'm a clinical pathologist, so I was never exactly in business, but I've been a fellow traveler, which is, I'm joking, really. But what I'm saying actually is that to a degree, the ability to take radiology studies and train well enough so that in some cases you get pathology-related information. There are a variety of researchers who've been doing that, and obviously that's very important. So, but I'm going to talk about the classification and the labeling. Okay, so why do we care, and why is this group so critical? So we actually have a couple of efforts funded generously by the SEER program. And so I'm going to talk about most of this in that context, but as you can imagine, obviously, ECOG-ACRIN trials are very analogous in many ways. Okay, so this is a piece of this slide is borrowed from Lynn Penberthy, who's our program manager at SEER. Okay, and what she does is to do essentially capturing claims data. Her program is capturing an increasing amount of correlative information. So, but this involves claims, and this involves basically how patients diagnosed with various types of cancers, what sort of treatment they went on. There are a couple of checkpoint inhibitors and targeted therapy and the like. So imagine being able to get the whole slide image for these patients and then generate a map of tumor-infiltrating lymphocytes, and which is something that we do actually. So these are the red folks are lymphocytes, and the yellow things are classified as tumor, and above you've got nuclei. So the sorts of things that will be doable and is doable now at a small scale because we're funded to do some of these things, as I'll talk about, is that going forward in 5, 10, 15 years, it will be possible to actually get tissue-level information about the immune status of tumors, as well as nuclear morphology on large patient populations, and ask, well, how did they respond to treatment? So these are potentially so SEER in similar sorts of patient populations, as well as we'll talk about legacy and ongoing trials at ECOG-ACRIN become incredible sources of real-world evidence, where you can look at things that the study had not been designed to look at up front. Okay, and as Stan alluded to, there are a variety of tools, and we've been developing quite a number of them. But the fact of the matter is these tools, as you heard in the earlier sessions, are built on standard backbones. Really, I mean, almost nobody, people who develop their own beautiful homebrew this and that, enjoy it. We've enjoyed it, but we've pretty much gone to standard stuff. I mean, we tune it in incredibly clever ways, but the fact of the matter is that Google, Facebook, the commercial sector has put huge amounts of effort and research into developing standard deep learning frameworks. You can download them from GitHub, and generally they'll work better than most of the things you sort of homebrew with your local people. So anyways, you can take a tissue and generate these sorts of patterns, and this graphic shows the tumor-infiltrating lymphocytes along with probability maps that tell you how likely it is you've got tumor in lymphocytes in given regions. And then we're working on a third generation of this that couples nuclear classification and area classification, so that hopefully we'll be able to get really tell you where all the lymphocytes are. And the world is moving in this direction. So, basically, in terms of planning the future, I think it's fair to say that with any program that one's thinking of in the next 3 to 10 years, you can assume that you'll really be able to have pretty good resolution data coming from pathology, as long as you can scan in the slides. So there is that. Okay, and this sort of graphic was the Cell Reports graphic involving some work that we did as part of the Pan Cancer Atlas project. Alex Lazar, who I understand is sort of Stan Hamilton's sort of semi-office mate, was a big player in this program, Vesti and Thorensen, and basically we went through and did a deep dive of molecular correlations of immune tumor as relates to spatial patterns of tumor-infiltrating lymphocytes, and ran about 5,000, generated maps for about 5,000 tumor-infiltrating lymphocytes. So this thing is now really, these methods are, if you run these things on the Google Cloud, it's about $1 or $2 per whole slide image to generate a prediction, right? So it's probably not at the point where you could say it's free. On the other hand, if you've got a few thousand digitized whole slide images and you've got some more elaborate study, it's certainly quite doable. So as other people have talked about, there's lots of work in the whole area of immune tumor interaction, as well as work relating tumor-infiltrating lymphocyte patterns and quantitation to outcome. And I won't get into that. But obviously, you have the current state, the current routine state, where people like Roberto Salgado, who leads the cancer, immune, I forget exactly the name of his group, although I'm part of it, where he's trained pathologists to look into the microscope and say this is the percentage of stromal TILs, and there's a bunch of complicated rules, and he's gotten pretty good concordance between them, and he's actually very on board in sort of trying to automate this process to varying degrees for the obvious advantages, not only of better reproducibility, but also because you can look at more subtle patterns as to how the lymphocytes cluster and ask how important that is. Okay, so you can also, as I've said, electronically circular segment nuclei. This used to be an absolute nightmare. There are probably 3,000-4,000 papers, including maybe 5 to 10 from my group before, say, 2014, of people who've said, oh yes, we can segment nuclei. And these things tended to work sort of well under some circumstances, poorly under others, and generally require a lot of tuning if you needed to run these things on whole slide images, particularly from new batches. And so the new generation of algorithms is much more reliable, and the ability to actually run large batches, I wouldn't say that you don't have to tune it at all, but again, it's something that can be scaled up, reasonably well. We're going to be releasing, well, we've released already actually 10 billion, more or less, nuclei from 13 TCGA tumor types segmented. We're going through QC, and then we're going to put it in TCIA and make it available to the research community. So for people who are not pathologists, which I would say would be most people, whole slide image is big. These are gigapixel images. And so if you have a million of these little guys in a single whole slide image, in several billion, even in a medium-sized study, and you're generally doing statistics talking about the size, shape, texture, and all of that, there's quite a bit of QC and analysis and software required to make that happen. But again, it's moved forward quite nicely. We have a couple of NCI grants from Information Technology Cancer Research that support these things, and there are 5 or 6 other groups. It's become quite popular. Okay, so then that wraps up a few things that I have to say about the, let's find the pieces and parts of pathology. So what I want you to take away from this is, rather than pathology being this mysterious and probably unpleasant seeming thing where people in basements look in microscopes and make mysterious pronouncements, you actually can think of it as moving towards a scenario where you get all the cells and you get all of the lymphocytes, and you've got the sort of, you can actually get a sort of symbolic description of what the tissue is. And then there's a huge amount that arguably can be done with this. So now I'm going to switch to the topic of classification. And again, people have been working on classification of pathology for a number of years. Our early work was with Hiro Shimada in the mid-2000s at Ohio State. He was at LA Children, and we had a brilliant mathematician, Metin Gurkin, who's still in the RadPath field, and Lee Cooper, who's now at Northwestern working with us, and a bunch of students, and we basically they hand-engineered machine learning codes that did a pretty good job of emulating Hiro Shimada on a good day. Okay, but they never really went anywhere because it was this incredibly, sort of finely tuned thing for neuroblastoma. So at this point, general algorithms are able to do much more of this, and there are various tricks that I won't get into that are involved. We've done some work in this that involves requiring only high-level training data. But actually, what I wanted to do was to talk about some work that came out of Google and UCLA very recently, and this is interesting for a bunch of reasons. So this has to do with automated Gleason scoring of whole slide images. Okay, so a few things to point out. One is deep learning algorithms, unlike traditional machine learning algorithms, require huge amounts of training data, or very, very clever algorithms that generate pseudo-training data that people vet. But it's a lot of work getting these things to work well. It's a lot of work from pathologists to teach these things. And so this was a huge effort, and Google sponsored it, and I have no idea how much it costs, but I think it'd probably be a lot more than the NCI would be likely to give a group to do the same thing. But they did a fantastic job. I mean, so here's some data actually, and Stan could have probably shown some other data. I'm sure he could have, but I think this illustrates this point of inter-observer variability. Okay, so basically they went through and they developed their Gleason group algorithm, and then they compared it to a bunch of pathologists, and they were very thoughtful about how they did things. They had 3 pathologists led by a senior GU pathologist sort of vetting everything. So ground truth was generated by essentially little groups of 4 pathologists. And so ground truth, so when we talk about accuracy, we mean accuracy with respect to this cobble of 4 pathologists. So you don't really know if it's accurate or not, but it's certainly different from the consensus. And the algorithm was a little bit better. Well, it's somewhat better actually than the average of the pathologists. But that's actually not as interesting as the variability between the different pathologists. So, okay, so some of you folks are probably biostatisticians. I'm not, but I hang out with biostatisticians as we all do. So let's say you guys are in California, you guys are in the Midwest, and you guys are in the East Coast, and say you differ. You have sort of a systematic geographical bias as to how you interpret Gleason group. And obviously there are differences between pathologists, and I'm sure they're not completely randomly distributed. So then if you have a nice ECOG-ACRIN study distributed between these groups, unless you have really a very, very careful central review, which you probably do, but if you didn't, then the pathologists, the California folks would see, would say, okay, well, just kind of making this up, would say, okay, we have people with not such bad prostate cancer, maybe 3+3, and then these guys would be 4+3, and these guys would be 3+4. I mean, because the thing is, these are differences in sort of qualitative ranking. And so the thing is that if you're doing a study, a statistical study, looking at any sort of treatment effect, and you have systematic variances in how things are graded, you're not going to get, you're going to have problematic results. You're going to have bias in your results. And even if you don't have bias and it's random fluctuation, it certainly increases your N. So I think a really actually interesting question, and I've had a lot of discussions, and I know some people have attacked this, but in terms of developing and phasing in central, sort of electronic central second review in pathology, actually looking to see to what degree this would actually improve the quality of the research studies and reduce the variance and perhaps impact, it should impact the confidence intervals and reduce the N needed to get a result. So I think that's actually potentially an important thing. So a few things about a couple of our studies. So we have a study funded by SEER with Rutgers and Kentucky and Georgia registry, where we're sort of going through the process of accruing patients and linking this with registry data. So this is intended to be what's hopefully the first step towards much more universal adoption, and the SEER program is very dedicated to bringing in new types of data, including this. We have another collaborative project with CBIT, where Warren Kibbe used to lead, which involves using a larger number of registries and then finding cases with PDAC, pancreatic ductal adenocarcinoma, people who've lived for a long time, more than 5 years, and breast cancer patients who didn't do as well as expected, and then essentially using the SEER program as a source of extreme data points. And then they've also been able to get omic analysis, omic correlative data. So we'll have a sort of a path correlative study. So incorporation into ECOG-ACRIN, this is to be talked offline, but there are obviously some very interesting discussions involving integrating this sort of digital pathology into these efforts. Tools are needed to do this. I don't have time to get into them, but in order to deal with the large amounts of data and the complicated workflows to make this happen, There's lots of tooling that's needed, and we've had some very, very interesting discussions with ACR about working with them on some of these. Cloud is very important in the sense that we can now run on your cloud partition. So in other words, you don't have to give us the data. So the idea so this could be, I think, very important in ECOG-ACRIN setting, where in terms of proprietariness of data, you don't necessarily have to give it away. So the tools allow a sort of flexible exploration. Be happy to talk offline, show you demos. Lots of people involved in this work, lots of overlapping teams. We've got a couple of, as I said, information technology for cancer research grants involving this, as well as a couple of SEER projects. So I want to thank our funders and take questions.